I also want to thank Dr. Nahida and Dr. Samer for the invitation and congratulate them on a great conference so far. And thank you for being here early in the morning to hear about child and adolescent mental health. This is where I work. This is the American University of Beirut in Lebanon. I always like to start my presentations with this one slide. It overlooks the Mediterranean Sea. It's a beautiful place. For those of you who have not had the opportunity to visit, you're welcome to visit. And I highly recommend that you visit our campus and medical center. It's a nice green area inside busy Beirut. So over the next 30 minutes, I'll go over primarily anxiety. I originally wanted to talk about depression and anxiety in children and adolescents, but then, when I looked at the schedule, I have only 30 minutes and I'd like to stick to the 30 minutes. So I'll focus on anxiety and may make some reference to data on depression as well. But basically, we'll talk about prevalence, talk about identification, course, treatment, prevention, some recent data, some local data, and some updates. This just came out in Lancet Psychiatry in 2022, which was a couple of weeks ago. Global burden of disease and where do mental disorders stand? And if you look at the ages 0 to 14 and 15 to 24, you'll see that anxiety and depression are among the top leading causes of years lived with disability, which is a measure of disability, basically. So for adolescents or youth, 15 to 24, depressive disorders are up there, number 2. And for 0 to 14, you'll see that anxiety is among the top 10. It's number 8. And again, this is very, very recent data. So, depression and anxiety do happen in children. They do happen in their anxiety specifically, and I hope that I'll make this, by the end of this talk, you will agree with me that it is the most prevalent mental health disorder in children and adolescents. It's highly comorbid with other disorders. It's underdiagnosed, undertreated, and as clinicians, whether in primary care or psychiatrists and psychologists, we need to look for it because kids often present for a different reason. These, just to show you the prevalence of the different psychiatric disorders. Again, anxiety is the most prevalent one among children and adolescents. I also like this slide because I often have a fellow with me or a resident who's shadowing my clinic. And when we have a new evaluation, and then I tell the resident, how old is the patient? And he'll tell me he's 4 or she's 5 or she's 7. And I say, do you want to guess why they're presenting for? And then, these are the most common presenting problems in children and adolescents to child psychiatry per age group. So early on, it is developmental delays, and autism spectrum disorder is the most common cause. For school-age children, you'll hear a talk after this one from my colleague, Dr. Hamouda, on ADHD. It's typically ADHD for 5 to 8 years old. And then anxiety presents typically in preteens and early adolescents. And then early adolescents to late adolescents, you'll see depression. Mental health disorders do occur in children and adolescents, and it's early on. If you look at the red curve there, you'll see that anxiety disorders, although they present in school age years around 8 to 9, they start early on as well. So you have kids who are 4 who may present with anxiety, kids who are 5 years old who may present with anxiety symptoms. But even earlier than that, we have what we call behavioral inhibition or temperamental traits that may predict anxiety disorders later in life. And we're talking here about really early on, infancy even. And there are a lot of experiments that were done in Boston, at Boston Children's Hospital, looking at inhibited temperaments where early young children or even infants would have really physiological symptoms and signs when they're presented with novel stimuli. Among the anxiety disorders, these are the different disorders and when they present: separation anxiety versus social anxiety versus GAD, generalized anxiety. In clinic, anxiety is not a great term. So if you wanna, in your history taking, ask kids and their families about anxiety symptoms, you should probably use a culturally relevant term. And I took this yesterday when Dr. Nahida was presenting. The leader here in Abu Dhabi used, how do you pronounce it? Chilon? Chilon. So this is, this is not anxiety, this is worrying. So depending on the culture where you are, you have to figure out how do people in this specific culture refer to being worried. And you have all of this, homesickness for separation, shyness maybe for social anxiety, apprehension, dread, worry. But asking a child, do you feel anxious? Maybe you probably will either get, I don't know what you're talking about, or get a no as an answer. Although we'll focus on anxiety today, but keep in mind that with the DSM-5, obviously, you probably know this, OCD was part of anxiety and became its separate category, and PTSD as well. Some of the things that special treatment that we'll talk about will apply to OCD as well. You have 11 different types of anxiety disorders in children and adolescents. What's interesting with the DSM was selective mutism moving from a communication disorder to become an anxiety disorder. So now we know that kids who have selective mutism are terrified of speaking in public. And we know that selective mutism in early childhood predicts social anxiety disorder in adolescents. I'm glad that the committee of the DSM made this decision. And we know also that separation anxiety can happen in adulthood. So they added to the criteria being afraid of something about away from workplace or safe environment, or just to make it also generalizable to adults. These are things to look for. I like this slide because it shows the physical symptoms of anxiety, and they're typically midline physical symptoms, from tension headache to perioral tingling, lump in throat, can't catch my breath, chest pain, abdominal pain, bladder urgency. So these kids present with a lot of physical symptoms as well. In terms of course of illness, we have what we call homotypic continuity and heterotypic continuity. For homotypic continuity, it's one anxiety disorder in early childhood developing into another anxiety disorder in late childhood. And for heterotypic continuity, you have one anxiety disorder in childhood developing into a depressive disorder in adolescence, typically. And this is something that is, also for those of us who see kids know that it's clinically very relevant. We see one child presenting at age 5, maybe with separation anxiety, and then they come back at age 10 with generalized anxiety, and maybe later at age 14, 15 with a depressive episode. When I was looking at the prevalence of anxiety disorders in the UAE, I found this study, and this is a population-based cross-sectional survey. It showed that 28% of the surveyed population, I think they were around age 16, showed clinically relevant anxiety symptoms. Anxiety is not only part of an anxiety or part of like an anxiety disorder necessarily, but you may have anxiety symptoms that are part of other disorders. Here in our case, This is a survey that we conducted in Beirut after the Beirut explosion, port explosion. Those of you who followed the news, we made the news for all the wrong reasons over the last couple of years. This is one of them. This is one of the largest non-nuclear explosions in history. Unfortunately, a lot of people lost their lives and several thousand individuals were injured and displaced. Our survey was just published a couple of days ago in the Journal of Affective Disorders. We looked at the prevalence of anxiety, PTSD, and depression in kids who were exposed to the Beirut blast in 2020. And guess what? Anxiety was the most prevalent disorder. It wasn't PTSD. Up to 73% of young children, or not young, but your children who pre-adolescents, 8 to 11, showed anxiety symptoms. 3 out of 4 kids who were exposed to the blast showed clinically relevant anxiety symptoms. Those of us who also, again, work with children know that, if kid is showing symptoms of anxiety, we need to also look to see whether or not this is a sign for something else, primarily, developmentally. There are typical worries depending on the age group. If they're worried about a ghost in the closet, this is not anxiety, this may be developmentally appropriate. What's interesting is that children with anxiety disorders also have comorbid physical problems, and then anxiety disorders do cause or have physical symptoms as well. So for example, kids with Crohn's disease do have comorbid anxiety disorder, and anxiety by itself or an anxiety attack or flare can cause abdominal pain. And then you have to figure out, is this a flare of their underlying Crohn's disease, or is the abdominal pain a symptom of anxiety? I find it fascinating and an area where I really closely collaborate with our pediatricians and our pediatric GI colleagues. In terms of screening for it or measuring its severity, we have locally or not locally, but scales that are available and validated in Arabic. This is the one that I like is SCARED, which is the Screen for Child Anxiety-Related Emotional Disorders. We had the opportunity of translating it and validating it a few years ago, but it's a highly sensitive tool. We use it to screen, and we also use it to monitor symptoms over time. It's available in English, and it's now available in Arabic as well. What's interesting also for us as clinicians, sometimes, when kids are presenting with depression, we definitely screen for suicidality. But if kids are presenting with anxiety, we tend to be more relaxed and think that, they may not pose a risk to harm themselves if they're just anxious. But actually, the data shows otherwise. So if you look at this large survey, you'll see that under anxiety, 9% of kids, and this is controlling for depressive symptoms, 9% of kids showed suicidal ideations, 1.6 of them percent had suicidal plan, and actually 6% had a suicide attempt. Again, this is controlling for depressive symptoms. So we have to keep this in mind. So kids, when they get anxious, even if they're not depressed, they may have suicidal ideations and may attempt suicide as well. Shifting a little to treatment, and here I borrow the data from the largest trial on the treatment of anxiety disorder in childhood. It's the CAMS trial, Child Anxiety Multimodal Study. This is a study where they randomized kids with different anxiety disorders minus OCD, although OCD was part of anxiety disorders back when this study was conducted, to either receive sertraline alone CBT alone, or a combination of both, or placebo, for 12 weeks. And then they followed these kids over several years and published on the long-term data as well recently. You want to take a guess what the data showed with the acute trial? This is 12 weeks after starting treatment. And you'll see that all the treatment arms were effective. All the 3 treatments were effective compared to placebo. So CBT alone did show benefit. Sertraline alone did show benefit. The combination treatment, though, was superior to both CBT alone and sertraline alone, with an 80% response rate. What was interesting, and I think this answers the questions that I get from parents, now that they followed these kids over years, they've classified them into consistent remitters, so kids who have remitted and did not have any recurrence, and kids who had relapses, and kids who have a chronic course that will continue to have symptoms over a chronic period of time. And it's often the case when parents, ask me after I make a diagnosis and tell them about treatment, is my kid gonna stay anxious through all his or her life? What's gonna happen in 3-4 years? What's gonna happen after we stop treatment? And if you look at the chronic course, you'll see in green there that those who had a chronic course mostly were non-responders in the acute trial, which means, if you respond during the first 10 to 12 weeks initially, this is a good sign. Chances are your course would not be a chronic course. So, and if you wanna look from the overall sample they had, this is the distribution. 20% remitted and remained stable, 30% were chronically ill, and half of them had a relapsing course. So if you have anxiety as a child, there is a chance out of 2 that you will relapse down the road. And if you do well early on in treatment, that's a good sign for you. If you don't do well early on and you don't respond, then chances are you're gonna have a chronic course. I think these are at least the way, the learning lessons for me from this big trial. I'm not a psychologist. I'm not going to talk about CBT, but I want to talk about parental accommodations. So no CBT with children if you don't involve parents and if you don't address parental accommodations. What are parental accommodations? For those of you who may not be familiar with this term, this is when the parents really, because anxiety at times and anxiety attacks may be associated with outbursts, with avoidance, etc. So what the parents tend to do is just to attend to the need of the child and feed the anxiety and the anxious thoughts by accommodating, basically. If the child doesn't want to school, they'll keep him at home. If the child doesn't want to go to a birthday party, they'll just keep them at home if they're socially anxious. Research is consistent that parental accommodation predicts poor prognosis and poor treatment response. So just I want to make sure I put a word out there that no psychotherapy is effective if it's done individually without involving the parents and addressing parental accommodations. Medication treatment is next. So SSRIs, basically, the trial was done for sertraline, but these are the FDA-approved SSRIs for children and adolescents. You'll see on the list there for depression, fluoxetine and escitalopram. But also we have a lot of interestingly, although this trial was done for sertraline for anxiety, sertraline is not FDA approved for the treatment of anxiety disorders in childhood, but it is for OCD. So we borrow the FDA approval from there. And in terms of dosing SSRIs in children and adolescents, this is the typical dosage that is used. Between parentheses are the studies that have shown data of either effectiveness or safety for the different SSRIs in this age group. TADS is the treatment of depression in adolescents. And as you see, for anxiety disorders, the effective dose, at least in the Kansas trial, is between 100 and 150. I think their average dose was 125. So really, we need to go a little higher than a starting dose to get to the effective dose in these children. In terms of adverse events on SSRIs, activation is very common. Those of us who have started kids on SSRIs, we do warn parents about activation, 10 to 15%. It's usually early on after we start treatment, usually within a few days to a couple of weeks maximum. It's very different than a manic switch or the switch to mania. It doesn't have necessarily the mood component of extreme irritability or euphoria that you see with mania. It's physical and behavioral hyperactivity. Bipolar switch is much less common than activation. Recently, there are a lot of also, I think the same applies for adults, literature on easy bruisability and GI bleeds. And we see this primarily bloody noses in children. We don't see much GI bleeds the way maybe we see it in older individuals. That made the news a few years ago, but I think it's several years ago, maybe more than a decade ago. But it's, I think, very relevant because with every single time I issue a prescription, parents ask me about whether this medication is gonna make their child commit suicide. And then, I have to give the spiel that looking at the data, yes, there is a small increase in the risk of suicidal ideations. This is for the anxiety studies. It's 1% compared to 0.2% for placebo. If you look at the depression studies, it's around 4% compared to 2% on placebo. So this is where doubling the risk came from. But you're really looking at 4% compared to 2% on placebo, versus a response rate of 60, 70% for depression, 80% for anxiety. And this is what I tell parents. You really need to compare the 60, 70% to the 4% or the 2% risk. And that this risk is on attempts and worsening ideations. It wasn't on the risk of completed suicides. So I think after I do this psychoeducation, some of them are much more comfortable putting their kids on medication, usually. Now, the last couple of years, this is just to let us know that, it's the pandemic has definitely worsened the mental health of children and adolescents. They're talking about another pandemic, mental health pandemic after the current pandemic, but this is the focus of also different policies, governments, etc. And for the sake of time, I won't present data here, but I had a few slides for a different presentation where I showed how depressive symptoms, anxiety symptoms have worsened in children post-pandemic. There were a couple from China before lockdown, after lockdown, and the rates were quite significantly elevated. Just as a clinical observation, at least in my practice and from my discussion with colleagues, we have been seeing a lot of school refusals this year, whether it is school phobia or social anxiety, I'm not sure, but many children who have been at home doing their online learning, at least earlier this year, came to see me because they were not able to go back to school because of extreme anxiety. So this is, I think, something that has to do with the pandemic and online learning and the worries that were associated with it. Lastly, the last 2-3 minutes. I'll say a few words about prevention, and some of you may have heard me present on this. We have, so I didn't have the opportunity to show you our national data, but when we did our national survey, we showed that although in general, mental health problems were prevalent in children and adolescents in Lebanon, only 5% of children with mental health conditions were getting any kind of help, 5%. So they were not accessing any help really. So we thought, you know, if they're not coming to us, let's go to them, and them, their natural environment is the school. This is where they spend 8 hours per day. And we looked at different school-based programs, and we chose this one in particular. The Friends translated it to Arabic, adapted it. This is a program that teaches kids basic skills, resilience building skills, and it has been shown to decrease symptoms of anxiety and depression in children and adolescents. And you know, it's nice because each word stands for a core skill that is taught over 1 or 2 sessions in class. F for managing feelings, relaxation. I is for cognitive restructuring, exploring solutions, etc. This is an example of a session where we teach kids the feeling thermometer. It's in Arabic, but it's an activity where they learn about, again, intensity of feelings, labeling feelings, managing feelings. This is one of the parent, it was a research study, so this is, I was doing some introduction and parent recruitment session here. This is the program being delivered in one of our underprivileged school by one of our research assistants. They talk about friendships a lot, as well as part of social connectedness, and this is an activity. But basically what we showed is that this program has helped, when we did an RCT, has helped decrease symptoms of depression and anxiety in kids who ended up receiving it compared to kids who were on the wait list. And for those of you who want to learn more about it, we have this publication out if you'd like to take a look. This is my email address, so if you have any questions down the road, feel free to get in touch. Thank you.